Cool. And I forgot. I'm sorry. Dr. Manning is graduated from the Ohio State University. So if you're not from the Ohio State University, sometimes you have to find a doctor who is to tell you why the is so important. But with that, Greg, take it away. Let's get started.
Okay. Well, look, we actually just changed this very first introduction slide like 5 seconds ago because the last time we did this, I think it was 5 appliances to treat 95% of our patients. But I guess statistically speaking, this is going to only be 92%. Basically, what this presentation today is going to be about is we're going to just try to find a couple of appliances that work with a handful of different scenarios, knowing that there's not a one size fits all. Option. I kind of want to start off with some general stuff. I don't know everybody on the who's participating today. I don't know what level of experience you all have, but I think it's probably worth a little bit of build up, and we will get very specific with the appliances that I use. And I guess when I say the 5 appliances, these are 5 appliances that I use all the time. These are the 5 appliances that I use. If somebody comes to me with a scenario and says, hey, what do you do if they're this? I can say, I have done this with this patient. So everything that you see today is not because they're the best necessarily, not because they are paying me to say that. It's because I've used them. They work good in my hands in different scenarios. So we'll go through that. So that's what today is going to be about. But before we start, I think it's worth noting, if we are going to be sleep dentists, if we're going to be dentists that treat sleep, or we're going to be exclusively sleep dentists, we really need to know, oh, you know what? I'm struggling here. Why it's not bouncing ahead for me here. What? Sorry, kids. Okay, we're back on track. I think it's worth noting that there's, roughly 30, excuse me, 30 million people that are suffering from sleep apnea, and so many of them don't know that. As dentists, we see an awful lot of patients in our chair. We see an awful lot of patients in our hygienist's chair. We're going to see, and this is not going to be a webinar on screening. That's a webinar we could do in depth, of full hour, and just how to screen patients that come in through hygiene. But I think it's worth noting that as we start to screen, we're going to find patients that need help, and they may not know they need help. They may even be resistant to want help. But there's a lot of people that have sleep apnea. Some have been diagnosed, some haven't, excuse me, diagnosed, and some haven't. And some we might have to help out getting their journey started. But with as many people as there are in this world that suffer from obstructive sleep apnea, it would be foolish to think that one appliance or even one treatment modality is going to be a one size fits all for that many people. And it's just not the case. So, when we talk about treatment options, and as a sleep dentist, we're either a sleep dentist that does sleep apnea and can talk about sleep apnea and can navigate this disease with patients, or we're a guy that takes impressions and makes a night guard. And I would really hope that as we go on this journey, wherever you're at in the journey, if you're just getting started, if you've been in it for a long time, I would hope that the goal is never to be the guy that makes a night guard for somebody, like a special night guard with hooks and bars and things like that. I'd hope that we would know enough that we could be versed to be able to talk to our patients. And I think that when we see these patients, it's worth being able to go through all of these treatment options. And really, there's kind of 5 here. There's 4 branched off of the middle lifestyle. I don't often tell patients, hey, you're super fat, and if you weren't so fat, you'd probably be better, because not everybody that has sleep apnea is fat. But there are plenty of times that we may have to have an awkward discussion about lifestyle with some patients, whether that's a sedentary lifestyle, getting more active and moving around, maybe doing some kind of exercises, losing weight, whether we talk about, I just noticed that there's an article coming out about some of these new weight loss medications like tirzepatide or Ozempic, Mounjaro, maybe even worth talking to some of these patients about those options. But past that, treatment options, past lifestyle, of course, we've got CPAP or any kind of PAP therapy that we can talk to patients about. We can talk to patients about surgical options, whether that is invasive removal surgeries, things like that, all the way to implanted surgeries like the Inspire, some sort of surgical procedure that might help them on their way. Um, we're obviously, as dentists, going to talk about our mandibular advancement devices or oral appliance therapy. And then look, it's for anybody that's ever treated sleep apnea in patients or large swaths of patients and had conversations with lots of people. It's interesting how some people you can tell you can talk to them about a sleep study, you can talk to them about having a sleep study done, or you can have results of a sleep study that their doctor made them take, and talk to them about the danger of this disease that they have, and they still don't care enough to do anything about it. So, there's always that option of doing nothing. Um, as dentists or just as sleep professionals, the quote at the top is, the one thing we want to take off the table is do nothing. Often I say, I don't care if you go have surgery. I don't care if you have Inspire. Fantastic. That's great. I don't care if you have surgery. Some of the invasive ones are not as effective as we might hope. Um, I definitely don't care if you go have CPAP. I'd just like you to be treated. I think you would feel better, do better, be better, healthier, all of those things if you would get treatment. So as we discuss things with patients, we just want to do nothing off the table. We want to talk to them in a way that they understand the importance of being treated. Now, as we do that, we can talk about the benefits and the risks of and alternatives of doing nothing or having surgery or doing PAP therapy. But one of the things that we want to basically get across to them is that there is not a one size fits all. There's going to be patients that come to you because they want mandibular advancement that maybe aren't great candidates for a mandibular advancement device. There may be candidates that come that don't want to do anything, or they want to do nothing, or maybe even they want to do surgery. And you're looking at their sleep study and you're looking at them and you're doing an oral evaluation and you think, God, you would benefit so much from having oral appliance therapy. Or at least I would assume that you would benefit from oral appliance therapy. Why go into something like a surgery? And in fact, I don't know that general medicine knows much about this study, but it's worth noting that back in 2015, so we're coming up on 9 years since the American Academy of Sleep Medicine, and that's not the American Academy of Dental Sleep Medicine. This is the American Academy of Sleep Medicine. Their 2015 guidelines started laying out that mandibular advancement or oral appliance therapy could and should be used as first line therapy for mild and moderate patients. If your AHI is anywhere from 29 and lower, you know, the chances of having success with oral appliance therapy is very high, at least to some degree. And when you start to think about that, it's worth having the discussion with these patients, because some of them are going to be CPAP non-tolerant. Some of them are going to come in and they're not going to want to even attempt CPAP. Some of them are going to be very anti-surgery. And we sometimes are the least invasive for a lot of these patients. Least invasive while they're trying to sleep without a mask on their face, least invasive surgically opening them up. We have a lot of things going for us. If you look at the bottom, it says, what do you think patients are going to be more accepting of, oral appliance therapy or a CPAP machine? Not only what are they going to want ahead of time when they're just thinking about, do I want to have the hose? Do I want to have the mask? Do I want to have all that? Or do I want to have something that goes in my mouth? Just right away, that's appealing. You start talking about travel and having to check the thing and drain it and all that kind of stuff, or just throw this little thing in your overnight bag. Obviously, the idea of mandibular advancement is more appealing to patients just here. But when you start looking at the statistics, the success rate and also the compliance rate, probably better said, the compliance rate with oral appliance therapy is much higher with patients than CPAP tolerance. So we're going to kind of leave that as a general dentist that treats sleep. I would hope that you would be able to discuss some of those things with your patients in a way that you don't look or feel uneducated, or you don't feel dumb, or you don't feel bad, because I really think that those are things that you should be talking about. Comprehensively discussing sleep and then narrowing it down for those patients to oral appliance therapy. And then once we decide that we're going to do oral appliance therapy, what are going to be the benefits and the risks? What are going to be the alternatives to that? What are going to be some of the things we're going to want to stay away from? which appliance do we want to choose based on that patient? And that's where we're going to go from here. So when we start talking about oral appliance therapy, obviously mild, moderate patients, I love seeing mild and moderate cases. We tend to have quite a bit of success with those patients. A lot of times they're maybe even a little bit younger, that some of their symptoms aren't so crazy, but they're starting to have some of these symptoms where they're feeling a little crappy, they're feeling tired, they're feeling wiped out. Maybe they're getting a little bit of blood pressure, they're getting into their 40s and 50s and their blood pressure is going up. I like treating those patients when they're mild and moderate because we start seeing kind of the fruits of our labors right away. Now, a couple of the risks, and we're going to go through these right here. For me, some of the two biggest risks for me are TMD patients and periodontal patients. And I put periodontal in red because I think it's a little more dangerous. And I'll go through that in just a second. But with periodontal disease, you just gotta be careful. And we'll leave it at that. Again, we could go through all of this list of possible side effects of oral appliance therapy. It's a completely different webinar, and we're not going to necessarily go there except for how it relates to how we choose the appliance that we want to choose. But the cold and fast of it is I'm always a little careful with TMD patients, and I'm really careful with periodontal patients. And I'm talking about severe periodontal, maybe class 2 mobility, definitely class 3 mobility. But interesting article here as well that talks about for those patients that have TMD pre-existing, that the signs and symptoms that they don't experience significant exacerbation of those signs and symptoms. Meaning if they're already having some TMD issues, to do mandibular advancement or oral appliance therapy on them does not exacerbate those symptoms a ton. This is a peer-reviewed article that has gained a lot of traction and by very reputable sources that say, hey, look, just in general, those patients that have TMD signs and symptoms, they're not going to get way worse. Now, for those patients that don't have TMD symptoms and we start oral appliance therapy and they develop those, just know most of the time those are transient. They come and they go. They're temporary. They don't stay a long time. There's things we can do with stretching and muscle relaxing and massage and titration. Again, that's going to be a totally different webinar, but just know that as we help our patients choose oral appliance therapy, those are going to be some of the things that we're going to be dealing with. And since TMD is one of those things, probably worth just chatting about it really quick. So when we've kind of gotten to the point where we've talked about everything with the patient's ready to do oral appliance therapy, what is going to be the right oral appliance for that patient? And obviously all patients are different. Patients tolerate different things. They have signs and symptoms of different things. Some of them have anxiety about different things. A couple of things that we could just go through, and I'm going to for the next couple of slides, we're not going to spend a lot of time on. The next couple of slides is me throwing the kitchen sink. We will get very specific because this is a 5 appliance course. If you just went through and listed the 5 appliances that I use and the situations that I use, this would be a 10-minute webinar and we'd all go home, but we don't get our CE if we do that. So we kind of have to drag this out and you get to listen to me flap my gums a little bit longer. So the next couple of slides is going to just be sort of the kitchen sink thrown at you. You can take pictures of your screen if you want. We're not going to go through all of these different appliances, but I just want to let you know what's out there. And then we'll get very specific after that. And when I say what's out there, there's literally hundreds of different appliances. There's appliances for every scenario. There's a bunch of different people making oral appliances, and they're all going to tell you why theirs is better than everybody else's. And look, there's probably some that are better than others. I gave up on studying the minutia of it a long time ago. I found some that worked for me in different scenarios, and that's what we'll go through later in the presentation. But, there are newer appliances. If you've ever done some of the older appliances and patients didn't tolerate them or they didn't like them because they were bulky or they felt like they were a mouthful, some of these newer appliances are far more streamlined. They're a little bit easier to titrate. They're a little easier to adjust, but mostly they're a lot more comfortable. A lot of these are made digitally, scanning and milling, so they can keep them streamlined and comfortable. So these are some of the newer appliances. Most of the newer ones are being made by ProSomnus and SomnoMed. Those are who, if I'm going to do one of these new wave ones, I'll usually use something by ProSomnus or SomnoMed. Now, there's plenty of those for lateral bruxers. Patients that are moving around, patients with a lot of tooth wear. We want something robust. We want something that's going to be able to move. This is just a quick list of them. I'll go through what I use for lateral bruxers in a little bit, but there's there are things for lateral abductors. It's not a contraindication, is what I'm saying. That if just because they're a bruxer or they're a heavy clencher, there's appliances out there that they could still use. Now, for those that do have a joint diagnosis, for those that do suffer from signs and symptoms of TMD, again, remember, we're probably not going to exacerbate those and make them way worse, but I would choose an appliance that has micro titration. Some appliances have like block titration, like when I change a band or I change this, you go from one set to the next, and it's a like it moves it out like a set amount. Like, oh, this is again this I changed this band, it moves it out a millimeter, or I changed this band, it moves it out half a millimeter. Those are fine for a lot of people, but if you have a joint diagnosis, some of these where you see this little yellow arrow on the side, or these little titration um, like screws on the side, kind of this kind of thing, that lets you know you're going to be making these very small spinning, these micro titration is what they are. You can move it an eighth of a millimeter with a quarter turn or something like that. So might be worth thinking about for somebody with a joint diagnosis to be able to move them out so slightly. If a big jump, throws them all off, that might be something to consider. Um, Obviously, another thing to consider would be mouth breathers, and really anything that you can put an anterior window, a breathing window. You could basically add these elastic hooks to help keep them closed the best they can. You can add those to almost any appliance now. Milled appliances, traditional appliances, they can be done in ball clasps, they can be done in acrylic. There's a lot of ways to get these anterior hooks on there. So another consideration, for mouth breathers. And then lastly, this is very, very uncommon, but for those patients that have allergies to metals, there are plenty of metal-less appliances out there. Those that don't require any metal titration devices, whether that be the bars or hooks or anything like that. And then even less than that are patients that are allergic to all types of acrylics. There's some vinyl ones that you can make, like the Panthera. There's options, is what I'm saying now. How often you need those options? Probably few and far between. I've actually never in 16 years had a patient with an acrylic allergy. I don't say that they don't exist, but obviously we made a slide about it, but I've never had one. I've had some metal allergies, but I try to use a metal-less appliance whenever possible anyway, just for comfort. We'll go through that too in a bit. So lastly, when we're getting ready to order the appliance, whichever one we choose, we just want to make sure that we articulate to the lab what we want. If we want them to completely be covered over second molars, put it on there. If we want to have hooks for elastics in the front, make sure you put it on there. We can't assume that the lab will do that for us. We have to make sure that we articulate that. And then whatever we tell the lab, don't settle for anything less. Again, anterior airway space. But whatever we put on there, if the lab sends back something and it's not what you want, send it back. I mean, it's kind of crappy for the patient to wait a little bit longer, but make sure you're giving the patient what you want. I mean, if you're on a webinar that's going to be talking about appliance selection, it definitely means that you've given some thought to not just a one size fits all appliance. So if you're giving thought to what you're going to put your patient in as far as an oral appliance, then you should get what you're after and make sure you articulate exactly what you want to the lab. So kind of what we've all been waiting for. We're like 15, 16 minutes into this webinar, and we're actually like 20 minutes in this webinar, and we're finally getting to the point. Like, good job, Greg. You've milked this thing out long enough. This is the 5 appliances that I use. Again, this is disclaimer. I guess I'm supposed to do that at first. Nobody pays me to use their appliances. I don't have any contracts with anybody. I strictly have these 5 appliances because I use them in my practice. I use them these are the ones I use. So I can speak to them because I use them. They're not the only ones I use, but these are the 5 appliances that I use the most. Chad, do you have
Hey,
something you
Greg.
want to jump in on?
I did. And I just want to say, it's really cool. One of the reasons we want to do this webinar in part is that we don't have any sponsors that are appliance manufacturers either. We just said, Greg, what do you do? Let's share it with these folks. And so today, this is a non-sponsored, this is just what Greg does. So ask your questions. I'm glad that we could offer that tonight. And it's just a little special treat. So yeah, that's it.
Awesome. Thanks, Chad. And again, I want to go back and say that does not mean that there's not other appliances. There may even be better appliances. These work in my hands. These have worked for my patients. My staff knows how to adjust and titrate. My staff knows how to seat them. We're familiar with them, and they work. And between the five that I'm going to show you, they cover just about all different types of patients. Now, I did throw in a bonus sixth, and I'm going to start with that one because we've done a little bit more of this lately. I don't love doing it. One thing that we can talk about at the end, and I think I even have a slide if we have some questions about it, our practice does a lot of medical billing. That is where you know if a practice is doing a lot of medical billing, you know the dentist is stupid. So I hate to say that about myself. I tend to be a little self-deprecating as a joke, but medical billing is a tough game. Luckily, we got into it and we've just kind of been riding it. We are in network. That's a big question. We're in network, but the reason why I throw the sixth one in here is because oftentimes, in our practice, we do a lot of screening and we do some home testing and we do a lot of, we get referrals in from people, and oftentimes we'll get somebody that we send home a test to screen them, and it comes back and they have all of these signs and symptoms that you would think, oh, this person probably has apnea. You get the test back and just, objectively, they don't have a diagnosis of sleep apnea, but they still are a big time snorer, or they still feel a little tired, they still feel like they make noise or whatever. So we've this is the sixth bonus one. You can put this one down. I don't love this, but we treat snoring occasionally. We also have a Solea laser. It has a snoring airway function to it where we can zap the back of the palate to try to tighten that tissue a little bit. It's designed to help with snoring. I put that on there as so that you know that this is an adjunct, and that if you are going to be talking about medical billing and moving into the medical world, this is outside of the medical world. You can't bill for somebody that has a diagnosis of snoring, but they can still be treated. And I'm not saying go out and buy a Solea either, but this is one of the things that we do. And when we do, we use this Glidewell a Silent Night or an EMA. Why do I use those? Because they're less expensive. Because I can't charge the patient, I can't charge their insurance, and I can't charge them as if I'm treating them for sleep apnea. So I don't charge the same price as I'm treating somebody for sleep apnea. So since I can't charge as much, I have to be able to keep my lab bill in check. And this is a pretty decent. When you see one of these, they're pretty decent and pretty quality for what you spend on these. I don't know exactly what they are, but I think they're less than $200 for the Silent Night through Glidewell. Chad, you jumped on something we want to talk about right here.
Well, actually, one of our questions was, what do you think about Glidewell Silent Night? So,
Yeah, look, Glidewell has a Silent Night that is actually FDA approved and is PDAC approved, oddly enough. That is tough to do. So congratulations, Glidewell and Silent Night. PDAC means that Medicare will cover it. And that's not an easy thing to get Medicare to want to cover an appliance. They sort of have their list that they made in 1974, and they don't like to deviate from it very much. So the fact that Glidewell got a Silent Night through there, so I like it. That being said, they have limitations, and the Silent Night does not come. The FDA approved one for sleep apnea that's PDAC approved does not come with a warranty, and they know that because they are not as robustly built. So I like it. I use it. In fact, we even use their PDAC when sometimes when patients are required to have a PDAC appliance, but they're reimbursing like $900 or something like that. We give them the option to pay cash for a nice one, but we just let them know, like, this is what your insurance covers. So we use it. And for patients that want to live completely within their insurance and knowing that their insurance company doesn't care if they have quality or not quality, we use the Silent Night by Glidewell, and I think it's great. And look, Glidewell, I know they're a big operation. They don't know me from Adam. I don't know them from Adam. We just use them like everybody else. They're easy to work with. They don't give us a lot of trouble. Not that other labs are trouble. Some of them are a little harder to work with. Some of them are a little bit more fussy, and some of them take a little bit longer, and their customer service isn't what I love. But Glidewell's pretty easy. So I got nothing bad to say about it other than it doesn't come with a warranty. And you can definitely tell when you're holding this versus, like on the model, like like an Avant, you can, which we'll go through in a minute, you can definitely tell there's a difference when you hold them. You can definitely tell one is a little more robust than the other one. So
Well, one more bonus question since you talked about the laser. How many treatments do you typically do? By the way, I'm saving billing questions and treatment planning fee questions to the very end because that's
yeah, because that's what everybody
auxiliary.
likes. You have to get
Yeah,
through the
yeah,
crap in order to talk about the good
yeah.
stuff. Like, how am I going to plan my next vacation around my sleep practice?
Right,
Like
right. How many laser treatments do you typically do with a patient?
I usually do three.
Okay.
And we can save all the billing stuff to the end. I do three. I do, if you have a Solea or you're thinking about it, I do usually do about 100 zaps spread out across the palette. I don't draw on it or grid it. I try to just eyeball grid and go across. But I do about 100 zaps. I do it 3 different times. I would not ever want, and I charge $250 a session. So the 3 sessions is 750. It's I would only do this, and I'm not trying to say Solea is not great. I love Solea for a lot of things. I would never do this with if it wasn't an adjunct to something else. I think it does really good if you're going to treat somebody even just with a like a silent night for snoring, and you're going to try to offer them some other treatment for their snoring. Then I'm super duper comfortable doing that because the results can be great when you're not just turning them back to the same type of sleeping and breathing that they had that caused that in the first place. And what I mean by that is the trauma of the vibration of the soft palate stretching that out and the tissue getting more flaccid over time. If you tighten it with the Solea and it actually tightens up enough to where they're feeling good about it, they're still going back to sleeping the exact same way, and that can just repeat itself. But if we're advancing the mandible and we're opening the airway, some of that turbulence is going to be lessened. I think the chance of this adjunct laser therapy lasting longer and being more effective are higher. So I 750 is a lot, but I feel like if it's a snoring patient, you put in a silent night that's not super duper expensive, and you put that as an adjunct on top of it, spreading it out over 6 to 8 weeks, you know, I feel super comfortable doing that. To do it as a standalone treatment, I don't love that. I know that they say you can do that, and it you can and it works, but I just feel like they got to that place all on their own with no help, and you could tighten that up, but they'll find that place again all on their own with no help. So I only do it if they're getting some other kind of help. So
Cool.
that's that.
Awesome. Thank you. I'll get out of here for a little while. With lots of questions coming in, so that's awesome.
Good.
We'll get to a
Well,
lot
this
of
was the
those
bonus
down the
appliance.
way.
This was good.
Yep.
Yeah, this was just the bonus. This is not part of our 5. This is the bonus 6 to get out of the way, because it seems like somebody always asks about snoring at the end of these kind of things, and then we end up losing all the good stuff because we end up talking about the stuff that we're not going to do quite as much. So that being said, this first appliance that I'm going to talk about is an EMA appliance. Now you can see I've got one right here. These are also very much like the Silent Night. These are inexpensive. Um, they're not super duper robust. They have a very minimalistic design. In fact, they feel kind of like 2 thick Essex retainers with little buttons on the side to hold these little straps. And then the way we titrate it is we move to different size straps. That's just the way that we work with those. So why am I saying this is one of the 5 that I use? One, it's easy to fit, it's easy to use, and it's minimalistic, but I use it because it's cheap. And I want to explain that. I use it because it's cheap, because this is the appliance I use as a temporary appliance for patients that are undergoing large dental treatment plans. And a lot of times it's my patients. Like, I'm putting patients through large dental treatment plans. The reason why I say that is because I don't mind taking like a $180 appliance and grinding the heck out of it and destroying it over the course of their treatment, to where when they're all done, I can make them a permanent appliance. And a lot of times, if I know that I'm going to treat a patient and want to get started treating them right away, sometimes I'll just incorporate my lab cost, or like $200 into their fee, where they just pay me the lab fee for this, and I pop it in right away, bill out the regular appliance because this is FDA approved, bill out the regular appliance, go through their treatment, carve this thing up as I need to. Once it's all carved up and they're done with their treatment, I throw this away and I make them something that's a lot better, and everything's already been sort of billed. I don't charge again. That's just kind of the way we do it. Um, so I bring this one up because the scenario that I use this is if a patient has a treatment plan that I know is going to take a few months or some time, we want to get them treated, or they're in an appliance right now and they need a lot of dental work and we want to keep them in an appliance. This is the one I will use as my temporary appliance. There's a lot of there's some appliances that are made strictly as temporary appliances. This is not. I just like it because it's a good appliance to carve up. It's a good appliance, kind of standalone, and this is my temporary appliance. So appliance number one is the EMA appliance. I use it because it's inexpensive, easy to adjust, and I can throw it away when I'm done. Okay. Next. The next one is called the Moses Express. In full disclosure, I have used this appliance in 16 years. I've used this appliance twice. If I've only used it twice, why in the world did I incorporate it in this appliance? Like, give me the good stuff. If you've only used this twice, why are you bringing it up? The reason why I bring up the Moses Express appliance is it is one of the very, very few appliances that can be used for patients that are in clear aligner therapy. For those patients that are in Invisalign or Sure Smile or Clear Correct or whatever those are, this is one that you can mold and shape over and over again. The back you have to heat up. It's sort of like thermacryl. You heat it up, you mold it to the teeth as they are, and then when they're switching and things are moving around, you can just heat it up. Because past that, it is very difficult to use an oral appliance when somebody's Invisalign because they're constantly changing the orientation of their teeth and the appliance itself. I mean, obviously the Invisalign needs to be worn all night long. Those are the free hours that you have to wear it, the 8 hours that you're sleeping or 7 hours that you're sleeping. The hard hours are when you're awake. So you definitely want to wear your Invisalign while you're sleeping. So if we need to use something while somebody is in active orthodontics like Invisalign, this one can be used. It's used over the top of their trays. The trays go in. We mold these back. The backs of these here are gushy, kind of squishy. These are not fantastic. I'll be honest with you. They're okay, but they're really the only real great thing out there for patients that are in clear aligner therapy. So again, number one, I use as a temporary appliance, the EMA. Number two is the Moses Express. I use that strictly because we've used it for patients with clear aligner orthodontics. Remember this, we got to cover 92% of all of our patients. We are probably going to run into some patients that are in clear aligners and they want to do it, or they're already doing it and they want to do clear aligners. There's an alternative there that we can use, and that's the Moses Express appliance. Okay, very good. That was appliance number two. Number three, bear with me on number three here. This is the Somnodent Classic appliance. I put in the Classic just so you can see what the Classic looks like. The Classic in and of itself, this has been around for years and years. In fact, the very first appliance I ever made was that one right there in that beautiful pink color. It looked just like that. I don't use this appliance a lot. These are the ones that have a wing and a block. That little block adjusts to push the wing forward, and then that wing is on the lower jaw, and it pushes that lower jaw forward. The reason why I would use this, I live in Arizona, and Arizona is the state where everybody from Minnesota, Wisconsin, Iowa, Illinois, it's where they come to die. We have a lot of snowbirds. We have a lot of older patients that live here. We live very close to a massive 55 and older community. So we see a lot of those patients, and actually they're my favorite patients. They're usually the most chill, and I love them. I joke around about them coming here to die, even though it's kind of true. But this appliance works good for two reasons on a geriatric population. One, these each insert independently, meaning that you put the top in and then you put the bottom in. And as you're putting the top one in first, the bottom one can sit on the bathroom counter. And once the top one's in place, then you can put the bottom one in. And for some patients that have dexterity issues, to have appliances that are locked together or hooked together, it can be difficult for them, dexterity wise, to get it in and out. So for patients that need to have an appliance that goes in where the two pieces are independent of each other for dexterity, this one works pretty good. Now, even more than that, because you can navigate your way through dexterity issues with a lot of different appliances. But one of the big things about the geriatric patient and this Somnodent Classic appliance is that this is one of the fairly decent appliances that you can use on edentulous patients. Um, we are actually, like Thursday, getting ready to seat one of these appliances on an edentulous patient. And they are edentulous not only in the top, but they're edentulous on the bottom. And we're actually, one of the reasons why it's taken us a little bit of time to make this one is we've actually taken, he has a lower locator denture. And so we actually embedded the locator snaps inside of this lower Somnodent Classic. But this is where they really do need to be independent of each other, because if you have them hooked together with a hook or a bar, you know, they can pull each other off fairly simply. Whereas when they're independent of each other, we can get the seal at the top, we can get either the snap or the seal on the bottom. So this makes the list because of its ability to be used independently, independent arches for dexterity, but also for edentulous patients, and it can embed locators in it if we want. So that is why I included in my list of 5 appliances the Somnodent Classic, is because it's good for my geriatric patients for dexterity, and it's also good for my edentulous patients. That's the Somnodent Classic. That was number 3. Up till now, we've talked about some scenarios that are very few and far between. Out of the 92%, those probably covered 7%. Well, we're just making up numbers. That now that we've gotten those out of the way, those are sort of our off scenarios. Like, I have a lot of dental work to do, so I need a temporary appliance, or I'm in Invisalign, so I need to have something that I can remold, or I don't have any teeth, so I need an edentulous one, or I can't hardly move my fingers, so I need independent arches. Those are the one-offs. Those are not going to be your daily drivers. That's not going to be the one that is your like go-to every time. So since we only have 2 left, I will go to my last 2 that are my daily drivers, the ones that I use the most. The first one that I use the most is a Herbst appliance. A Herbst appliance is good for a lot of scenarios for me. One, if we look at my bullet points, right on the top, I put it because it's affordable, and the code E0486, which is the code for oral appliance therapy, it's Medicare approved, which means it's PDAC compliant. Now, what's interesting about that is that a while back, Medicare decided to make a list of appliances that they would cover, and they called that list PDAC. It's basically like what's in network. If you're going to be in network with Medicare, they have sort of an in-network list of appliances that they cover. And they call that PDAC, PDAC approved appliances. So this one is PDAC approved. And again, like I said, I live around a lot of older people, so we have a lot of Medicare. And so Medicare, this is a fairly good appliance that Medicare covers. It also is, the sad part about all of that is Medicare is, look, I'm not going to get too into it, but if you ever want something done right, definitely let the federal government do it. It's full of savvy, motivated people that care so much about everybody. So obviously Medicare is way smarter than everybody else. So the fact that they made up this rule about PDAC, interestingly enough, for as much as we joke around about Medicare being broken and all that kind of stuff, it has been to our sad realization over the last few years that when Medicare makes a change to what they cover and their guidelines, all other private insurances tend to follow. And it's been interesting to find that as Medicare approved a handful of appliances that are considered PDAC appliances, how many other medical insurance companies now are mandating that we use a PDAC or Medicare type appliance. So it's sad, if you're going to be in network and you're going to bill in network medical insurance, you'll find yourself doing a lot of Herbst because it's one of those that's on the list and it meets a lot of our guidelines. It's great for lateral bruxers. It can be micro titrated. It's fairly robust. You can put anterior hooks on it. You can put anterior windows for breathing. It kind of is a little bit of a jack of all trades. Obviously, where it falls down is comfort. To have two big metal bars in your cheek is a little bit rough. The other thing is that the titration mechanism is on the maxilla. It's up in the posterior maxilla. And the reason why I bring that up is because a lot of us don't have a lot of room in the posterior maxilla before it starts banging into the ramus of the maxilla. And a lot of times this can pinch and push against the tissue up against the ramus of the maxilla. So it does have its limitations, but as just a general kind of catch-all appliance, the Herps is great. The other thing is that there's some labs that make fantastic Herps appliances. There's one in Arizona that I really love. They make a really good Herps appliance, and they're reasonable. I mean, for the quality that they are, they're a reasonable cost. And they're local to Arizona. I mean, they do business all over the country, but it's really nice for me because they're local, and I really like the guys that run the lab. But the Herbst appliance for me is probably one that I do the very most. It's not my favorite appliance, and I also have sleep apnea. I forgot to mention that when I first started, and I've been treating myself now for about 10 years. And for the first 4 of 5 of those years, I used a Herbst appliance. I had the lab that's local here, and some friends over that lab make me one, and it worked great. I loved it. It was fantastic. I have a little maxilla space, and I don't know, it wasn't that uncomfortable to me. It was not crazy for me. And I used one, and they work good. Unfortunately, I use this most because I'm sort of forced into it by in-network medical insurance. That's really one of the biggest reasons. Now, the upside to these now is that it used to be that they were ball clasp retained, and I don't love ball clasp retained anything, because ball clasp retained anything, whether it's an appliance or whether it's a flipper or whether it's a retainer, they tend to create space, embrasure space, and they can open up contacts for food impaction. So I don't love ball clasp retention that much. But a lot of these new Biflex liners, Biflex is something that's made by Somnomed, but a lot of them will have these, thermal acrylic kind of rubbery liners, and I really like that. And you can get your Herbst with that too. I also like that these new Herbsts have this little ruler on the side to help you know exactly where you're at in your titration. Some don't have that ruler, and if you ever get off, you end up having to go back to 0 and then titrate out, because whatever you do to one side of the Herbst, you have to do the other side. If you do 4 little twists on this side, you got to do 4 little twists on that side. So anyway, this is in there because this is my daily driver. I make a lot of Herbst appliances because I'm in network. That being said, I don't wear a Herbst appliance at night. Moving on to the last of these 5 appliances, I tonight will wear an Avant. Last night I wore an Avant. For the last 5 years, I've worn an Avant. I like the Avant because it's comfortable. It does a fine job. I don't know that it does any better of a job with my sleep apnea than any of the other appliances that I've had, and I've had 3 or 4 different ones. I feel like they all worked great. This one is very comfortable for me. It has that Biflex liner. I feel like it's almost like a retainer for me after I had orthodontics. It's very streamlined. The other thing is, if you notice, the way we titrate these or move this is with bands, and these bands come on a little card. I forgot to bring it into my office. And the way we adjust it is we just swap out the band. This one you can see says M0. That means it's a medium width arch. So if I want to move them out a millimeter, I would go to M1. And they just snap onto these little balls, and they slide through this little groove right here. These are sort of ovoid, so that they go on sort of up and down, and then once they're spun in this direction, they can't come off. This little white part right here goes into this slot. It's slightly thinner right here, so you snap it through that little slot, and then you slide it on, and then it's thick enough where this won't come out of this little groove here in the front. It's very streamlined. You can have the hooks built into the acrylic if you want to have rubber bands. This one is the one where if I'm going to work outside of somebody's insurance and they're going to pay me cash for an appliance and my service, that I'm going to follow them for a year and do all the titrations. We sort of bundle that all together, one cost. You get me for a year. We do everything, including follow-up testing. If somebody's going to pay me cash for that service, I will give them this Avant because I feel like they'll be most comfortable in this appliance. I feel like it works great. Like many of the other appliances work great, but on top of that, it's comfortable. It comes with some warranty through their lab. Um, so when patients ask me, what do you use? Now, that being said, I also have used for those that are going to ask, I've also used the ProSomnus Evo. I really like this. I really like the Evo. I'm sort of just a little bit of an idiot, and to do the upper and then kind of switching out the trays, I'm sure it's easier than I make it, but I always end up having to look at some chart to move those things around. I know I should probably just memorize it, and I could use that a little bit more, but this one's pretty easy because I just go from one band to the next band to the next band, and it's just a 1, 2, 3, 4 as I'm titrating out. So it's easy for patients to do it at home. That saves us appointments. We can do appointments virtually, like we can make phone calls or Zoom calls to patients and say, how are you feeling? And do all that subjective stuff that we do during a titration appointment. But we can say, all right, let's move you to the next band, and the patient can do it at home without having to drive in. So that's another reason why I like it. You can do the same thing with that ProSomnus Evo. But I end up having to look at a little chart and be like, okay, now do this one with this one. And it's fine. They work great and they're very comfortable. They're very minimalistic. The ProSomnus are too. But day to day, when we have a patient that wants the nice appliance and they want the, they're going to pay cash and get the best, this is the one we give them. So that is the 5 appliances. Now, the biggest thing that we're trying to achieve is patient compliance. That's why I like that Avant. It's very comfortable. But patient compliance comes in a lot of ways. There's some patients that will never even get a chance to put an oral appliance in their mouth if it's not covered by their insurance. I think we know who these patients are. They come to our dental practice too, where they want the filling made out of duct tape and baling twine. It is what it is. So we have to find one that's covered by their insurance. We have to find one that's not only covered by their insurance, but that we can afford, but they'll be compliant because they can pay for it, or they get it through their insurance. Um, some patients want to be compliant strictly because of comfort. That's where we can start talking about why some appliances are more comfortable than other appliances. But the number one goal is patient compliance. And we really want to start looking at this through the lens of what our patient needs. Again, some of our patients need a budget-friendly option. Some of our patients need something that's covered through their insurance. Some people need something that's comfortable and non-invasive because they have sensory things. But we do need to start when we're doing an appliance selection with the patient, those are the questions that we have to ask those patients, because everybody's lens is different. I'm always amazed at when people come in and they've got like a big old filling on a front tooth that's got like a black stain line through it, and you mention something about changing it out, and they're like, nah, I don't care. Some patients just tolerate things, and they just don't care about things. And then other patients, I'm amazed at how sensitive they are about the smallest little things. And for those patients, we want to make sure that we let them know, hey, there's options for all of those different things. And again, for every patient, what they're going to want or need is going to be different. The last thing that I want to put on here is that you want to be able to use appliances that your team can help with. It's incredible how little amount of chair time I spend with my sleep patients, because the nitty-gritty stuff, I go in every time there's a sleep patient in the chair, I go in and give them FaceTime. But there's so much of what can be done in a sleep practice that can be delegated to auxiliary staff. So you want to make sure that you have your staff trained, and you want to make sure that your staff knows what you're doing. You don't want to be the only person in your practice that knows anything about sleep. So that's, again, maybe my plug for wanting to get your staff trained, whether it's a CE course, a weekend course, so they can become familiar with it. You want to make sure, because your time is the most overlooked cost in your dental practice. You have to be spending a small amount of time in there. If you're spending too much time in there, you really start eating away at whatever your dental practice could be doing during that time, or how much, we're getting into that topic here in just a minute anyway, how much money you're going to be saving or not saving or losing. So one of the, besides these appliances, one of the things that I'm a big advocate for is team training. I'm a big advocate for team training. It makes my life so easy. My team, I'd put them up against any team, dental or sleep, in the world, but we get them a lot of training. We put them through a lot of CE, and they love it, because then they get to interact with the patients, and the patients look at them as very competent, um, and they know what they're talking about. So that's again, be careful of your time. Be careful of your time. So
Yeah, I do want to jump in and just we actually don't have a slide for it tonight, but we do have our 4th of July sale going on right now. I just put the link in the chat. We're actually discounting our July implementation course that Greg is teaching, actually. So you'll get to have more Greg. Yeah, July 26th, I want to say. And that is in the link there. So if you want to bring your team, I think it's only $400 for you plus 5 team members, 4 or 5 team members to come. Tons of CE, and you're there. Real quick, we've got a lot of questions tonight. So before we get to those, if you don't quick mind, Greg, go ahead and go a slide or two ahead. We just want to invite you, if you haven't already considered coming over to our Business of Dental Sleep Medicine course. We're bringing the top performing dental sleep medicine practices in the country, some sleep physicians and some marketing professionals together to really show you how to do the business of sleep. And Greg, if you go to the next slide, I don't know if you're sharing audio too. See,
I can go in and share audio if we need to.
see if it works. Well, we have a video for you. We'll attach it in the email at the end of the day as well, or that we send you tomorrow. That just shares about that experience. You can go to the next slide, Greg. That's okay. It just talks about the fact that this is an amazing event, and for those that do want to come, it's going to be spectacular. Now, we are going to get to your questions. So for those that are here for it and are able to stick around, we'll get to the questions. If you can't stick around, then I'm going to put this in the chat for you. You can take off, grab your CEs, and all that jazz. That is available in the chat for you as well. So with that, let's get to our questions. First
so I don't know if
question.
I don't know if it was a good thing or a bad thing that there's a lot of questions. Either I did a really poor job of getting this across where we've left so many questions out there, or I was so engaging that people just got their brains working. And so we're about to find out.
Well, first question, we'll try and go for the quick ones first. Name of the lab in Arizona that you like. We had 2 people ask for that.
Oh yeah, Gergens. It starts with a G. Gergens. Gergens Sleep Lab. They're actually an orthodontic lab. They started as an orthodontic lab, but Dave Gergens he's a pioneer in sleep. He's started he's one of the founders of the Academy of the ASBA, where I'm a diplomat, the American Sleep and Breathing Academy. I'm not endorsing. I'm a diplomat there. I like him, but Dave Gergens is one of their founders, and he owns the lab. So
Cool. Second question, do you charge differently based on appliances?
no, if somebody's just going to come in to pay cash, they're not going to use their insurance. I have a fee, and for that fee, I make sure they get a good appliance. The only thing that varies is patients' insurance policies. Like I said earlier, we're stupid, so we bill a lot of in-network medical. Some medical pays pretty good, and some medical does not pay really good. But most of the medical now requires us to do a PDAC appliance. So if they reimburse really low, and I can't even afford a $300 Herbst or a $350 Herbst because they're only reimbursing me $800, I may have to use that PDAC approved Silent Night through Gergens, but I will let them know that they're welcome to go outside of their insurance, but that their insurance, basically their insurance is limiting me on what I can make. But I don't, if somebody came in and they were just begging me for a Herbst and they don't want to bill their insurance, I charge my fee. If somebody comes in and they don't want to use their insurance and they don't care what they use, I use an Avant.
Cool. And I think it's a good time to say the views of the speaker do not necessarily reflect the views of
Yep.
those. We don't think dentists are stupid who bill medical insurance. It's strategic. I'm just
Yes.
kidding.
No.
Do
No,
you
I only
build a
say that because if you're thinking about it, it's a lot of work. It can be worth it. We do an awful lot in our office. We do an awful lot of revenue in our office through medical insurance, but it's a mountain to climb.
Yeah, yeah, and it, and it's funny because back when I started and Greg and I talked, we had some really funny analogies that are not appropriate for public television. But
We do.
I've been the anti-medical billing guy, and I've been persuaded that occasionally it is the right call. And in examples like Greg's, where you do have a lot of people who are older and all that kind of stuff. But I digress. Quick, hopefully maybe quick. Do you use the K code or the E code?
So that's where that's again where it gets really dicey. You really have to do these prior authorizations and these predetermination of benefits when you're doing medical insurance billing because there Medicare will not pay for the K code. And so it used to be that you could jump on like United Healthcare or Cigna or something like that, and you could do a K code, which would allow you to do an Avant or a non-hinged appliance. If you don't know the difference, an E code is a hinged appliance, and then the K code is the other type of appliances that don't have a hinge. And so when your insurance company mandates that you use an E code, the E0486 code, you have to use a hinged appliance. And for me, the best hinged appliance or the easiest one for me to work with is a Herbst appliance. Medicare, it will show up in their booklet that they have a K code listed, but they won't pay for a K code. If you bill a K code, it will come back as a non-billable code and they won't pay for it. As soon as some of these other insurance companies found out about that, they're saying to themselves, "Oh, Medicare's doing that? Well, crap, I bet we could do that too." And they won't cover it. And so it's been kind of sad that we used to be able to bill people's medical insurance and offer them an Avant or a Prosomnus, like an Evo. And now we really can't. We're sort of, if we're going to bill your insurance, we're mandated we have to do the E code. The E code is a hinged appliance, which means we basically have to make a Herbst. Maybe not as quick as we thought. And if there's a follow-up question to that, that's very confusing. If there's a follow-up question to that, throw that in the chat and let's make sure we get that question answered properly. But that's kind of the way
Yep.
that works.
And I
Again,
am jumping
I'm
around a lot,
speak.
so just
Yeah.
because I jumped ahead of you, I didn't miss anyone's question yet. Don't worry. So
And that
cool.
and that and that thing about the K code and the E code, you just want to find out what if you're going to just strictly be non-insurance, and you want to do the Avant, it's a K code. You have to use the K code because it's not a hinged appliance. So you just gotta. It's gotten to be a little sticky since the K code showed up. I don't think anybody's going to take away your birthday if you screw that up if you're just doing cash. But if you're doing in medical insurance as an in-network provider, you got to get pretty savvy on that.
Cool. Good words of wisdom there for sure. Julie asks, how do you titrate for snoring? Do you start them edge to edge?
I basically treat snoring patients exactly the same way as I treat sleep apnea patients. The sad part is I do the exact same thing. I just use a little bit of a cheaper appliance because I can't get paid as much for it, which is, and I mean cheaper, like less expensive, not
Mhm.
I'm not speaking to the quality because, like I said earlier, Glidewell's been great to work with in that regard. But I use that silent night. I still use the George gauge. I still do. I start them about 50%. Oddly enough, 50% for patients that just have primary snoring oftentimes is enough. I don't with snoring patients. I don't end up titrating them out a ton. Maybe a band, but a lot of times they're pretty oddly surprised at how well they do just at 50% of their maximum anterior posterior on a George gauge.
And you're probably not doing follow-up efficacy testing with those folks either, I imagine.
No, we don't. I mean, they don't. I hate to say it, but it's like they're
Yeah,
not paying for the full service. You know what I mean? It's
right.
kind of like they're
Yeah,
paying for a night guard, a night guard
yeah.
that makes them quieter. You know what I mean?
Well, on that, we've got Julie asked another question. Do you need a physician's note or letter if the patient states they've been tested and only have snoring if they want that corrected?
No, no, you won't be billing out that. There is a code for primary snoring, but it's not worth it. There's also a snore code in dental that you get, like a snore guard code in dental. I'd just probably build a snore guard code in dental and have a cash fee that because dental's not going to pay for it anyway
Do you
either.
require a copy of the test to make sure they're
Um,
actually just snoring?
For me, only because we do enough of it that I just don't want to open myself up for liability and risk. If somebody just comes in and says, "Oh yeah, my AHI was 3, but I snore like crazy," I need to see some documentation of it just for my own. But you know what? I've been doing it long enough that I've heard stories. I don't know anybody personally, and it's never happened to me, but you hear stories, and I just look. The other thing is, don't do anything sleep related except for the snoring thing that we're just talking about. Don't do anything sleep related outside of the purview of a physician. You know what I mean? It's just not worth it. You know, you think you're helping somebody out. And I just have this sneaky feeling that as sleep medicine gets more and more popular, it's going to get more and more scrutinized. And we just don't leave yourself open for that kind of liability and risk. Work with a physician through everything.
Yeah. Solid. Um, Dr. Stan asked, why not use a MyTap for a temporary appliance instead of the EMA?
That's what I said. There's a lot of them out there. We have a MyTap here, like ready to go. There's what was that other thing, that snore hook that we had
Hmm.
too, that we could use. The thing is anything that takes a lot of chair time to try to fabricate, I'm not like huge into. We tried that. We tried that MyTap on me. Like I was trying to like mold it on me, and my assistants were working, and my assistants are good. I mean, my assistants will do thermocrural relines, they do all that kind of stuff. It just felt cumbersome, and it's so infrequent that we have to do that because of large treatment plans that we've done that maybe 3 or 4 times with large treatment plants where we had to make an EMA, cut it up, and then throw it away. It worked for me. That was definitely one of those where in the presentation I said there's a lot of people that make appliances strictly as temporary appliances. You're welcome to look into those. This was just the Greg Manning school of what I do in my office.
Hmm.
So yeah, absolutely. If you can make those work in your hands and you could do it to, again, remember that last slide. Doctor time is precious time. So
Yeah.
if you have to be the one in there, like molding the snore hook or the MyTap, all of that kind of stuff, just be careful of how much time it takes. It takes me about 30 seconds to hack away at an EMA when a crown doesn't fit good. So,
Yeah. Um, Dr. Stan also asked, anything you don't like about taps in general?
um, no. And what's funny about that is I didn't grow up, I'll just say this, I didn't grow up using tap. Um, I have a personal tap. I had a tap made. I've had about 7 or 8 appliances made for me. I have a tap. I don't like the feeling of not being able to open my mouth. That locked in feeling, I don't really like. Um, the tap I have, and I'll give you for tap people out there. I don't have the good tap that has a lot of the movement. I don't have like the Tap Dream, some of these new ones. The tap I have is from like 9 years ago. I just didn't like it, and so when I grew up, I just never used tap. That being said, when I started using my Herbst, I had such good success with it that I just thought the Herbst was like the it was like the end all say all. It was sort of like the nirvana of appliances to where I was so happy with mine that I was like, that was what I was using with everybody. Now, again, this was before these digital like Avants and ProSomnus were out. And I had a patient come in with a tap and it was getting to be just beat up. He'd had it for like 8 years, and I said, "Oh yeah, we can make you a new appliance," and we're billing their insurance. And I made him a Herbst. I said, "Hey, there's a new one out. You know, you might like this better. It doesn't lock you closed." I made him a Herbst, and he came back after like 2 weeks, and he's like, "Oh, you know, I think it's working, but man, I sure like that tap. I really like that tap." He's like, "To where I've been using the old tap the last little while." Anyway, I at no charge, I made him a tap. And like my first titration appointment, he came back. He's like, "Oh, that's like wearing a good pair of shoes. That's just like, that feels perfect. That's what I like. I like the tap." So patients that use tap love tap. So I have nothing against it. It's just not been one that I've ever used. And partly because I keep saying it, when I was growing up in sleep, learning it, I didn't like it personally in my mouth. And so of course I'm like everybody else. And
All
so
right.
I push my hopes and dreams and fears on my own patients. So that's
Yeah.
I just never used one because I didn't like the feeling. But there's again patients that use tap and love tap. So
Yeah.
nothing against it. And they work great and they're good for a lot of scenarios. And also, oddly enough, that little thing in the front where it hooks, according to Medicare, that's considered a hinge. So it is a PDAC appliance also. And so it's an E code also. So it's going to be covered by a lot of medical insurances, which is fantastic. It's PDAC approved. So if you're in network with Medicare, you can use that. So I've got zero against TAP. I just don't use it because I never really have. But I don't know if that answers the question, but that's where I'm at.
Cool. Well, we're going to do a lightning round so we can get some of y'all out of here. So try in 10 seconds or less to answer. We're going to close off the questions. We still have so many questions. We did have a case study for Dr. Patel, but they left, so we're going to skip that question for now. Dr. Patel, if you do want to get that question answered, let us know. How do you treat posterior open bites with MAD uses? MAD use.
We're talking posterior open bite, like they can't get their bite back in after they've been using the appliance.
I believe so.
It's a tough one. There's not an open and closed answer. Morning.
Fun. No? Okay, keep going.
AM exercisers, repositioners, if you're worried about that, those are good. Chewing on something, reminding the patient that every morning, if they're getting their bite back in every morning, that's less. And when patients start getting lazy about that is when that starts to happen. Once it's happened, it's difficult. I mean, it's just one of those things where it's difficult. There's not a lot you can do. Let's just put it out there. Once that starts happening, there's not a lot you can do. I got a little bit lazy. I've also been using one for 10 years. I have a little bit of a posterior open bite. I can get myself back in, but it's a little bit of a stretch. When I'm chewing, I'm fine. But in my rest, sort of like when you're trying to go into that, what feels just kind of like a relaxed bite, I'm a little bit posterior open. So it does happen. It's not the end of the world. This was supposed to be 10 seconds or less, so I'll just end it right there. I had a funny story. Yeah. I'll leave the funny story out.
If you guys want to hear Greg's story, just shoot me an email after our webinar tonight. We'll get him to record a little video for you. Second lightning round, patient feels the urge to clench with any appliance. Tried the Evo and the Panthera. He doesn't like either. I think the question that's not actually in the question is, what would you do next?
For somebody that's clenching like crazy and fighting it.
Mm-hmm.
Write this down. My dad and my brother are both pharmacists. And I was completely unaware through any pharmacology class that I ever took in dental school, because there's some medication that's not super popular. Like not a lot of people know about it. It's in its own category, but it's a muscle relaxer sort of in its own category. It's not like cyclobenzaprine, Flexeril. It's not like carisoprodol Soma. It's not one. It has a short half-life. It is mild. It was sort of formulated for geriatric patients that were getting like cramping because they were bedridden or wheelchair bound or something like that. It's called Zanaflex. Zanaflex. It comes in a 4 milligram tablet. I have them take one at bedtime. I tell the patients it has a short half-life and that it won't likely make them overly groggy when they wake up in the morning. They may be a little more groggy, but it will wear off fairly quickly. It's not like, again, it's not like that Soma, Flexeril stuff that really loops people out. So when you say muscle relaxer, patients get kind of freaked out about that. A lot of patients that have been on those muscle relaxers don't want to do that because it makes them feel crappy. This is not one of those. Zanaflex 4 milligrams. I prescribe it and I put one refill on it, and I tell them one every night for a month until your body and your brain realizes that this thing's here to stay and it stops fighting against it. And if it takes a little bit longer than that, you've got a refill to go 60 days. If it's working and you want to do this for a long time, it is a medication that you can take nightly for a long time if you need to.
Cool. Great. All right. Next question. I recently had several patients wanting a night guard for bruxism, and they're using CPAP and happy with their CPAP. What sort of oral appliance, if any, could you consider for patient using while CPAP?
I mean, really, and if they're using CPAP and they're okay with the CPAP, really any oral appliance will do as long as it's made for a bruxer. Like a Herbst is great. Truthfully, a lot of these new ones, like Prosomnus is great for heavy. I mean, they'll take a beating. Avant will take a beating. Anything will take a beating. What you don't want to do is give them a traditional night guard that's just a single arch night guard, because single arch night guards for bruxers will make their apnea worse. As they bite together, if this top teeth and it's got a thick appliance around or a guard around it and the bottom teeth come to hit it, it will slide those bottom teeth back. If you put it on the bottom teeth and it comes to the top, it will slide itself back. So it will actually push back into the airway. Not a lot, but enough. I mean, we don't want any backwards. So that's the one thing. Do something that's less expensive because you're probably not going to get paid for it. At least not through medical insurance. So
well, and I actually I got my father-in-law into a CCAT OptiSleep. I liked that one a lot, and they're actually cheaper than a lot of other appliance manufacturers.
Yeah, OptiSleep is also extremely streamlined. If I was doing this presentation 3 years ago, 2 years ago, this one probably would have made the list. OptiSleep is a fantastic appliance.
They just opened up the ability to just submit a digital scan. They used to require cone beams. You can now do it with just a scan. So you do have to have a digital scanner, but their lab bill is about $550, I think, after shipping, $525. So
yeah, and they're good.
Great appliance.
They're super comfortable, by the way. And when you feel them, they look like a souped up EMA, but when you touch them, you can feel they're pretty quality.
Yeah. We have another question. Is there an appliance good for patients with bracket and wire braces?
No.
Cool. I heard
that was less than 10 seconds.
It was.
Look, you could try one of those Moseses, but it won't. I mean, you'll those brackets and wires will just like destroy that thing.
There was an appliance I heard of. I don't even know the name of it, but there's something if you Google it. But do your research, due diligence. We don't know of anything that.
Yeah, there was something a while back that somebody told me. I don't know about it. Somebody told me that used like Velcro or something like that, like some kind of like plasticky Velcro that you could it just like went over, like you could just like wrap it over or something, and then you can just like kind of find your bite and like bite into it. But it's not an not FDA clear appliance or anything like that. So
love it. All right. We're wrapping up here soon. We're in the lightning round. Wait, nope. We said no more questions, Julie. I'm sorry, and Michael. We'll try. All right. Is there any different feature you'd want in an appliance that the patient has all 4 wisdom teeth? Is there a certain appliance you'd use?
No, I'd use whatever I want. No, I mean, I wouldn't make that an issue. You may not want to cover those wisdom teeth just because that's a lot of times they're just so far back there that it starts compromising the tissue or like getting uncomfortable. So you don't have to cover those wisdom teeth if you don't want. If you can even get halfway through the second molar on most patients, you're pretty good shape.
Cool. What is your opinion on longitudinal studies such as Whisper for titrating patients, especially when monitoring them over the course of the year, leveraging telehealth?
I don't think I understood the question. I'm not smart. I'm not very smart. So what we're talking about longitudinal, are we talking about we're the ones doing the longitudinal study?
There's a study by Whisper, longitudinal studies of people with appliances doing titration studies to determine the effectiveness of those appliances long term and doing titration appliances. I think the question is, what is your opinion on the efficacy of appliances long term based on the studies that are coming out showing the different research?
Ass.
Okay. Yeah, I would say.
Look, I don't know. I'll have to look that up. I feel. Look, I got stumped. I don't know that I know much about that. I'm obviously I'm hearing about this, and again, I'd never ever claim to be like the scholar on this kind of stuff. I'm sort of the guy in the trenches. I'm the boots on the ground. I like to tell my patients that I drill little holes and fill them back up. That's sort of what I do. I'll fix teeth. I'm like a tooth fixer. So
I'll say this. One, that study's relatively newer. So if you don't, Greg's a single doctor practice that's got like 7 ops that are running.
Chad's gonna make excuses for me. So everybody listen up.
Yeah, no, but I will say there's longitudinal studies that actually about CPAPs and their decreasing effectiveness. This is a typical thing that happens in really any therapy that comes out, is we're going to see that as we grow, and our body has to work less hard to keep us healthy. Our body will work less hard to keep us healthy. So we're going to see some of that, but we'll kind of pause it on there. It's a great question. We'll do some research into it ourselves and maybe create some social media around it. Shameless plug, feel free to follow us on social media. We do a lot of sharing of really cool stuff there. Next question. Medicare's approved the Avant as of this past year, I was told.
Yeah, it's approved. It's made the list. They won't pay for it.
Also, and Greg said this earlier, so I'll say it really quickly, is you got to look at cost. What's Medicare going to pay you, whether you're par or non-par, for that appliance? Is it, I don't know what the lab bill is, but if it's not under $600, then you may or may not be making enough money to really make that for the Medicare patient.
And that's the big thing. We're in network. We're participating. I know that there's some Part F and whatever. I don't know. I know. I remember Alicia saying something about they when they get some of those plans in there, they make $5,000 in appliance or something crazy like that. And maybe that's the case, but and look, we haven't probably in at least a year tried to throw a K code at Medicare. So if you know something I don't, hit me up in the chat because we tried when it first came out and it hit it. We lost our shorts on a few of those because we tried to bill out the K code and just got denied. And then once you get denied by Medicare, just so you know, trying to get not denied for something else is a little bit of a challenge.
Well, Fahad Khan asked about the market in 2030 for appliance therapy. I just put a chat in there. Yahoo Finance says that it's going to be borderline exponential growth wise. So I'll put that in the chat for everyone as well.
Yeah, good time to
Oral
get into
appliance,
sleep medicine.
yeah, the awareness of sleep, especially following the COVID stuff and the fact that healthy sleep was such a factor in that. It's blowing up like crazy right now. So that's why we continue to do these webinars, because dentists not doing this are going to be left behind. So, do you see a value in AM aligners versus a morning repositioner by Somnomed?
Um, yes, that's the kind of the quick answer. I feel like if you're going to do either one of those, good for you. There's probably, again, I'm not a sort of smart scholar. There may even be studies and statistics out there that say that one is better than the other. If I have a patient that's struggling, I usually make an AM exerciser. It, I don't know. The lab that's local, they make a good one, and that Gergen's lab makes a good one. Some of the appliances come with like a little template thing to make a repositioner, and if they do, I'll make them. But I don't usually pay for them because they are they're kind of flimsy. They tend to break fairly easy, whereas those AM exercisers are like fun. They're fun to use.
Yeah.
So
Remember a story one time of a patient who had one of those little suction cups that went onto the shower. Yep. She lost her morning repositioner, just started chewing on that thing.
That was my patient, Julie.
Yeah.
That was my patient, Julie. Yep.
Yeah.
She lost her AM exerciser and she found a little suction cup holding a shampoo like little basket onto the wall of her shower, and she pulled the suction cup off and started chewing on it. And she said she liked that better than the AM exerciser. And at that point I thought, why am I paying for an AM exerciser? And I can buy a box of suction cups for so much cheaper. So
yeah, so whatever works with your patients, that's getting their bite back is the most important piece. And again, you guys got to consider your costs on the business side. If you have a patient that is not your dental patient, are you concerned about their dental status? Do you get clearance from the patient's existing dentist?
Absolutely. I do a dental exam on all my patients. I take a cone beam on all of those patients to check for periodontal disease. We do a periodontal evaluation, a tooth evaluation. And I also make sure that I communicate that I'm seeing their patient only as a sleep patient so that they don't think that we're trying to poach them. And I tell the patient I always, like all the specialists do for us, the specialists all say, oh, you're seeing Dr. Jorgensen? Oh, he's fantastic. You're in great hands. I make sure I do the same thing. Oh yeah, old Dr. Smith, he's awesome. You're in good hands there. Has he suggested anything? Does he want to do anything? Are you in the middle of any treatment? I always ask that kind of stuff. But if they're not active treatment, or I mean, I may see on one of my patients a big amalgam that's cracking and I want to do a crown on it. And then I look on a sleep patient and I see a big amalgam that's got a crack in it that I would probably do a crown on. It's not hurting them, and their dentist might be one that's just watching it or something like that. I'll still make an oral appliance on those patients. My dental exam is mostly to check for pathology.
Two quick questions, because those were actually all the questions. Let me cut it off. But Julie asked what that last appliance. I believe we were showing the CCAT OptiSleep.
Oh yeah.
If you want to pop that in, CCAT SICAT OptiOPTI sleep. I'll put that in there. Yep, that's it. We have their old they're an old contact of ours. They got some really cool software and stuff too. So that's what that is. And then Dr. Vlog said your favorite denture patient favorite favorite four denture patients. Greg showed the Sonomed Edentulous, which is a variation on the Sonomed Classic earlier. So that was an easy one to answer.
Yep.
He actually is delivering one this week, he said. So he
Yeah.
likes that
The
one.
first, actually, this is the first one we're delivering with locators.
Oh, yeah. Yeah. So yep. And actually, we have some models on that. We're working on an article right now for them. So keep posting on our social media and on our email marketing. We are going to be sharing we have an article from SoundMed on how to use the edentulous appliances specifically. So keep on the lookout for that. Folks, we have run out of questions. We have Mindy who said, this is one of the most practical lectures I've heard. You are great. There you go. And
Oh,
I have an
Mindy's
anonymous
Mindy was my
attendee.
favorite participant, just so we know. She was my favorite by far.
Yeah, and Mindy, we'll Venmo you. I'm just kidding.
Yeah.
And then an anonymous attendee said, "Peace out, homies." I'm just kidding. I think he meant homies, but appreciate you guys. Thank you for the 37 who stuck around. You did it. We're much later than normal, but please check out the links in the chat. We'll send an email tomorrow afternoon for your CEs. And if you want to learn more from Greg, go get that special. It ends on Friday at midnight, but it's half off right now. So it'd be really great to have you on the course. Get signed up for masterclass. And I think that's it. There was something else and it's gone. But appliance selections. Sorry, that's this webinar. Appliance complications with Dr. I've forgotten his name off the top of my head. Dr. Patel, Mayor Patel, is actually going to be in a month from now. So make sure to get on that. I put that link in the chat as well. You can find all that information and more at awakenasleep.com. Thank you for making it tonight. We appreciate your participation, and we'll see you guys on the next one. Have a great night.
Thanks, guys.